All right, so continuing with the interstitial lung disease today, we talked about, when we approach it from the plain film point of view, we talk about distribution. Is it upper lung, lower lung? Clinical history, of course, is the most important thing that is really going to help you in terms of your differential diagnosis. So if I tell you that this person is short of breath, we have this close-up that shows us these reticular markings here at the lung bases. So it looks like basilar predominant interstitial disease. And here's the CT scan on this patient. What do we think?
It's a consolidation.
There are some patchy opacities there, right? Consolidations with some air bronchograms. Anything else?
Is there bronchiectasis?
There's what? Yeah, there's bronchiectasis, right? So we see bronchiectasis, parabronchial thickening, right? And what about these kind of ground glass nodular opacities? What do we think those represent? Well, given the other findings, that look a little tree and buddish. So bronchiolitis. So what do we think is going on in this patient?
Like chronic aspiration.
Sure, that's probably one of the most common things to think about. So we have bronchiectasis in a lower lung distribution, these areas of abnormal opacity. So chronic aspiration, right? That's a very common cause of bronchiectasis, especially in a lower lung distribution. Although there are other things that can also cause bronchiectasis, but if we see this in adults, it's probably one of the most common things to come to mind. So bronchiectasis on chest radiograph, that can look like lower lung interstitial disease. So that is a consideration. Here's another example. This case on the chest x-ray, it looks like we have some ring shadows and some tram tracking. That can be a clue on the chest radiograph that you're dealing with bronchiectasis and not really an interstitial lung disease, right? So airway disease can look like interstitial lung disease. Here's another patient who has reticular nodular opacities, somewhat worse at the lung bases, and the CT scan looks like this. What do we have here? Yeah, so we have interlobular septal thickening, and when we have interlobular septal thickening, we try to decide what? Is it smooth or nodular, right? This one you think is well, what do you think, smooth or nodular? Yeah, it looks somewhat more nodular, right? So if we have nodular interlobular septal thickening, what do we think about then? Yeah, especially at the lung bases, lymphangitic carcinomatosis. Of course, the clue here, you have the metaport, so that's a giveaway, right? So lymphangitic carcinomatosis, that can also give you what looks like interstitial disease at the lung bases, but we're talking about the infiltration of the lymphatics there. So on chest radiograph, it can give you a fine reticular nodular pattern. You can have curly B lines. Sometimes it can look like pulmonary edema because of that basilar predominance. You can also have pleural effusions and adenopathy. So we've covered lymphangitic carcinomatosis. Nodular interlobular septal thickening is the key finding on CT, especially if it's basilar predominant. All right, so this patient has shortness of breath, and we can see some reticular opacities. The distribution is lower lung and peripheral, right? And the CT looks like this. Okay, so what's the finding on the CT now? Yeah, so there's honeycombing, there are reticular opacities, it's basilar and peripheral predominant. So this is the typical appearance. What pattern do we call this? When you're reading the CT, you call this what kind of pattern? UIP, right? UIP pattern, the disease that's associated with, as you said, was, IPF, idiopathic pulmonary fibrosis. Although there are other diseases that could also do that. But as far as the idiopathic interstitial pneumonias, that is the disease that we think about, right? So that gets us now into this category of idiopathic interstitial pneumonia. So the definition of this, not a very satisfying definition, non-neoplastic, non-infectious lung diseases resulting from damage to the lung parenchyma by varying patterns of inflammation and fibrosis. So, I mean, with that definition, I mean, why isn't sarcoid considered an idiopathic interstitial pneumonia? But, historically, this is what we have. So these are clinical radiologic pathologic entities, meaning that to be able to arrive at a diagnosis, you need the input from the clinician, the radiologist, and sometimes the pathologist, often the pathologist. And so at many centers, they will have an interstitial disease conference, a multidisciplinary conference, where these cases are discussed, just like tumor board, where you have the radiologists, the clinicians, and the pathologists get together and try to arrive sometimes at a consensus diagnosis of what it is that they're dealing with. So many times this does require a multidisciplinary approach. We get into the alphabet soup, which makes it very complicated, but all of this started with Lebo in 1968. He was a pathologist at UC San Diego. How about that for a dream job? Okay. So he was the first to classify these chronic interstitial pneumonias, and he classified them based on 5 types originally, based on their histologic appearance. And these types that he's describing should not be considered separate diseases, but responses of the lung to injury. So regardless of what's causing the injury, the lung is limited in terms of its response to that injury and in terms of the histologic or pathologic patterns that you see as a reaction to that injury. So that is the thinking here. And in his original classification, UIP, usual interstitial pneumonitis. By the way, why is it called UIP?
It's the most common.
It's the most common. So what would happen was, that somebody with interstitial lung disease would go get a biopsy. They'd go down to the pathology. What do you see? I see interstitial pneumonitis. Or what type? It's the usual type. It's like everybody else has. So it's just caused that because it's the most common, right? DIP, discriminative interstitial pneumonitis, and you'll see when we get into that one that really is a misnomer, completely misunderstood. BIP, which then came on to be called BOOP, and then as an idiopathic interstitial pneumonia, because this terminology is confusing in and of itself. The idiopathic interstitial pneumonia is COP, cryptogenic organizing pneumonia, associated with that particular pattern. And then there's LIP, lymphocytic interstitial pneumonitis. And originally he thought GIP was an idiopathic interstitial pneumonia, but it turns out that that is caused by a hard metal pneumoconiosis. So that's no longer one of the idiopathic interstitial pneumonias. Since then, other entities have been discovered just to add to the complication of the alphabet soup. So we have AIP, acute interstitial pneumonitis, NSIP, nonspecific interstitial pneumonitis, RBILD, respiratory bronchiolitis, associated interstitial lung disease, and the newest one, PPFE, idiopathic pleural parenchymal fibroelastosis. And we'll talk a little bit about each of these. Not all of these are idiopathic, as it turns out. We know that DIP and RBILD are associated with smoking, and LIP, there's controversy as to whether LIP really exists as an idiopathic interstitial pneumonitis. Most patients who have LIP have some underlying autoimmune disease. We also see it with AIDS, and we could see it with stuff like Sjogren's. So most patients who have LIP on biopsy have some underlying cause. Whether it exists as an idiopathic entity in and of itself is somewhat controversial. Not all of these are interstitial. I mean, we think of interstitial disease as giving you reticular patterns on chest radiograph. But AIP, DIP, COP, these give you alveolar opacities, especially on CT. So they don't really look like interstitial pneumonias. Also, we have to differentiate idiopathic interstitial pneumonias from hypersensitivity pneumonitis and underlying collagen vascular disease. Patients can develop fibrosis, especially UIP patterns and NSIP patterns from rheumatoid arthritis or other scleroderma, other underlying collagen vascular diseases, so they may be secondary to that. It's important for the clinician to figure that out And we also have to make sure that you're not dealing with a case of hypersensitivity pneumonitis, which can be treatable by removing the patient from the offending environment for these diseases. There are four categories for these classification of idiopathic interstitial pneumonias, and you do have to know this. There are the chronic fibrosing idiopathic interstitial pneumonias, IPF, NSIP, smoking-related DIP, RV-ILD, acute or subacute COP and AIP, and the rare idiopathic interstitial pneumonias, LIP and PPFE. There's also a slight difference sometimes between the histologic pattern and the clinical syndrome, or the actual disease name that we attach to it. So the histologic pattern of UIP is associated with the idiopathic interstitial disease of idiopathic pulmonary fibrosis. NSIP and NSIP are the same. Organizing pneumonia is the histologic pattern associated with COP. Diffuse alveolar damage, essentially ARDS, is the histologic pattern associated with AIP. DIP and DIP are the same. Respiratory bronchiolitis is the histologic pattern. But if the patient is symptomatic, the actual name of the disease, we call that respiratory bronchiolitis associated interstitial lung disease, because you can find this in asymptomatic patients who smoke. But if they're symptomatic, we call it RB-ILD. And then LIP, PPFE, and PPFE are the same. There are reversible and self-limited diseases like RB-ILD. If the patient stops smoking, it can get better. Reversible with risk of progression, the more cellular forms of NSIP and some fibrotic forms of these diseases. Stable with residual disease, especially NSIP. Progressive irreversible disease with potential for stabilization. The more fibrotic NSIP gets, the worse the prognosis. And progressive irreversible disease despite therapy. Unfortunately, that many times is the case with idiopathic pulmonary fibrosis, and also occurs with the more fibrotic, along the more fibrotic spectrum of NSIP. So what is our role as radiologists in approaching this? Well, we want to describe the disease. We want to use standard terminology when we describe the disease. Determine the distribution of disease, axial distribution, central, peripheral, craniocaudal distribution. Rule out UIP. Is it typical of UIP or is it not typical of UIP when we look at the CT manifestation? Fibrosing versus non-fibrosing or inflammatory disease, because that does have implications as far as therapy. So there are now antifibrotic agents, and regardless of the cause of the disease, if it's causing progressive lung fibrosis, the clinicians can try to treat patients with antifibrotic agents, as opposed to inflammatory diseases. So inflammatory diseases are treated with immunosuppression and steroids. So our reading of the CT, whether we think it falls more in the fibrosing spectrum or the inflammatory spectrum, regardless of what the underlying cause is, has implications as far as how the clinician will treat the patient. Findings of honeycombing, traction, bronchiectasis, architectural distortion, volume loss, all of that on CT are manifestations of fibrosing disease. And then we look for ancillary features, because this is also important in terms of the differential diagnosis or what we think the underlying disease might be. And all of these things we want to look for it because it has implications in terms of what's the underlying disease. So if we cyst on the CT, what do we think about? What diseases do we consider?
Lipid lamb.
So LAM and LIP can be associated with cystic lung disease. What else? What else gives you cystic lung disease?
Emphysema.
Emphysema, but that's not typically cysts. Emphysema has a different appearance. Villi are different than cysts.
Langerhans.
LCH, right. So those are your typical cystic lung diseases. Perilymphatic nodules. Sarcoid, right, especially in somebody who has lung fibrosis. If we see perilymphatic nodules, we want to bring up the possibility of sarcoid. Central lobular nodules.
HP.
Yeah, hypersensitive pneumonitis gives you central lobular nodules. You can also see it with pneumoconiosis. Silicosis can also give you. What did you mention?
RB.
Yeah, if they're ground glass nodules, RB-ILD can also do that. Tree and bud, we think about What gives you tree and bud?
TB.
What?
TB.
TB, infections, bronchiolitis. So that's not an idiopathic interstitial pneumonia. So if we see tree and bud opacities, we're thinking of infectious causes, okay? And then air trapping, bronchiolitis obliterans, if that's the predominant abnormality, right? Which of the diseases that we've already mentioned might be associated with air trapping?
Hypersensitivity.
Yeah, especially hypersensitivity to pneumonitis. If there's fibrosis with a large amount of air trapping, you want to think about hypersensitivity to pneumonitis, right? So these are all things that we would consider, right? So starting with UIP, insidious onset, progressive shortness of breath, restrictive lung disease, 5 years survival, not very good with this disease, although the antifibrotic agents have helped in terms of treating this. Causes of death, number one cause of death, respiratory failure, no surprise. Second leading cause of death, cardiovascular disease from the chronic hypoxia can accelerate underlying cardiovascular pathology. Lung cancer, though, is the third leading cause of death in patients with idiopathic pulmonary fibrosis. So this does place the patient at increased risk for cancer. So you have to have a high index of suspicion when you're reading cases of somebody with significant pulmonary fibrosis, if they're nodules, spiculated lesions, about lung cancer, because they are at increased risk. So what happens with UIP is that there's repetitive damage and abnormal wound healing that results in pulmonary fibrosis. So the fibroblastic foci, this is this kind of conglomerate of fibroblasts, one of the histologic hallmarks that the pathologist will look for. So there are multiple microscopic foci of injury, fibroblast proliferation, collagen deposition, and it's recurrent injury. So different parts of the lung will be at different stages of repair, and it progresses, unfortunately, in many cases. There will be alternating areas on pathology of normal lung tissue, acute injury, repair, and fibrosis. So that's called a temporally heterogeneous pattern. And so the interstitium is thickened by fibrous tissue and inflammatory cells. The fibroblastic focus is what pathologists will look for, in that temporally heterogeneous pattern also is what the pathologists will look for. All right. In the later stages, you get honeycombing, and typically it's peripheral and basilar predominant, so you'll have this honeycomb appearance of the lung from the severe extensive fibrosis. On chest radiograph, reticular opacities, the interstitial markings, but it can have a characteristic peripheral distribution, so it can have this L shape, basilar and L-shaped distribution. So that can be very typical of it. And holes, what we're looking at is the areas of honeycombing. So you might see very tiny holes if you look carefully on your chest radiograph, and low lung volumes because it really is a restrictive disease. So L-shaped distribution, basilar predominant. When you look very carefully, you can see the tiny little holes in there on the chest radiograph. Those are those areas of honeycombing that we can actually see sometimes on the chest radiograph in these patients. If you're not sure from the frontal view, if you're dealing with interstitial lung disease, look in the retrocardiac region on the lateral view. That should be a relatively clear area. If you look very closely and you see lots of reticular opacities there, that's abnormal. All right, and that will increase your confidence that, okay, we're dealing with some kind of interstitial disease here. We should get a CT on this patient to categorize it and see what's going on. Another example, reticular opacities, basilar, peripheral L-shaped distribution. That's the typical appearance of UIP or IPF as the underlying disease that can cause this. And the CT correlates very nicely. You have reticular opacities here, honeycombing at the lung bases, right? And subpleural honeycombing in the periphery. The normal secondary pulmonary lobule, you have the central lobular bronchiole, the central lobular artery. In the periphery, you have the veins and the interlobular septate. What happens with fibrosis is that the small, tiny little airways within the secondary pulmonary lobule become stretched and distorted. And that's what gives you the honeycombing appearance. It's traction bronchiectasis. And it's the scarring that stretches the tiny little airways within the secondary pulmonary lobules. And then that's what gives us the coarse honeycombing eventually as the disease progresses. And so on CT, you'll have this characteristic appearance of peripheral subpleural honeycombing. So we recognize these as honeycombing as opposed to emphysema because the cysts have thicker walls, somewhat thicker walls. Also, they're stacked. So these thick-walled cysts that are stacked, right, that's the appearance of honeycombing on CT. You may have areas of ground glass opacity, but if the areas of ground glass opacity are associated with these areas of honeycombing, then the ground glass opacity probably represents more fibrosis below the resolution of the CT. If you have ground glass opacity, though, away from areas of honeycombing, that tends to be associated with more of an inflammatory component, and that's where you would want to direct biopsies in these patients. Because if you biopsy areas of honeycombing, you get end-stage fibrosis, which is not very specific as far as for the pathologist trying to interpret that. So you want to direct to areas of more active inflammation. Okay. When we talk about ground glass opacity, it's very nonspecific. So imagine this as a voxel on a CT scan. Normally, the air spaces there, the alveoli are full of air, so it's very low in attenuation. But what can give you ground glass? Well, just loss of volume, just atelectasis can give you ground glass. If we have interstitial disease with fibrosis along the interstitium, that can increase the intensity of the voxel, that can give you ground glass. So even fibrosis can give you ground glass opacity. And then if you have an alveolar process, if you have fluid that is filling the alveoli, that can also give you ground glass on CT. So ground glass all by itself on CT is a very nonspecific finding. And then, just another typical appearance of a UIP pattern, peripheral subpleural honeycombing. And so we call that a UIP pattern. And if the patient has clinical findings associated with IPF, then the patient can be treated for idiopathic pulmonary fibrosis. Although realize that IPF is not the only disease that can give you a UIP pattern. That's why we call it if you're reading the CT, you would call it a UIP pattern. You wouldn't necessarily call it IPF. You would say it's a UIP pattern consistent with IPF, right? What are other things that might give you a UIP pattern on CT? No, NSIP looks different. That gives you an NSIP pattern on CT, which we'll talk about. But what other diseases might give you a UIP pattern?
Rheumatoid arthritis.
Yeah, so connective tissue diseases like rheumatoid arthritis and also scleroderma, those patients can also have a UIP pattern that can look just like this, okay? What pneumoconiosis sometimes can give you a UIP pattern? Well, which pneumoconiosis gives you basilar interstitial disease? Asbestosis, yeah. So that's why we refer to it as a UIP pattern that is consistent with IPF, and those other diseases have to be considered. So here's a case of ground glass, right? And we also have traction bronchiectasis. This is something you want to recognize on CT. Okay, so traction bronchiectasis indicates that there's fibrotic disease, especially if the surrounding lung is abnormal. So you have the surrounding lung here is abnormal with traction bronchiectasis that tells us that this stuff is fibrosis. This patient has fibrotic underlying disease. Even though we don't see frank honeycombing, the traction bronchiectasis tells us that this patient has a fibrotic lung disease because we have traction bronchiectasis with abnormal surrounding lung, okay? Or bronchiolectasis too. Sometimes if you want to differentiate dependent atelectasis from interstitial disease, you can do prone imaging, right? So if the abnormalities are persistent on supine and prone imaging, then it represents true interstitial disease. You're not dealing with dependent atelectasis. As opposed to dependent atelectasis, right? Some ground glass opacity. Sometimes it might look reticular at the bases. You turn the patient prone, it goes away. So that's just dependent atelectasis if that happens to come up as a question. For early interstitial lung disease, you might want to scan the patient's prone, although that's not routinely done. If I show you this and I ask you, is this typical, which one of those choices would you pick for this patient? What would we pick?
Probable.
Why? So what are the findings on the CT?
So I don't see the typical UIP, like the peripheral.
So you don't, what specifically don't you see? You don't see
Honeycomb.
honeycombing, right? You don't see honeycombing, and it's that peripheral subpleural honeycombing. If you saw that, then you would say it's typical UIP. But in this case, what do you see? How would you describe this? You would call these
Ground glass.
no, this isn't ground glass. These are what? How would you describe that?
Reticular.
Yeah, these are coarse reticular opacities, right? So we have some coarse reticular opacities associated with some traction bronchiectasis. So there is fibrotic disease. So if we have a peripheral distribution of coarse reticular opacities and evidence of fibrosis with traction bronchiectasis, that is a probable UIP pattern, all right? If there was honeycombing, then it would be a typical UIP pattern. Both of those categories have a high probability of having underlying idiopathic pulmonary fibrosis. So these UIP patterns on CT, the typical UIP pattern, reticular opacities with honeycombing, basilar and peripheral, no inconsistent features with UIP. Lung biopsy is usually not necessarily. Same is true with a probable UIP pattern. If we have reticular opacities, basilar and peripheral, no inconsistent features, even though we don't have honeycombing, again, it's probable UIP lung biopsy, not necessary in that case, as long as the clinical findings are also consistent with idiopathic pulmonary fibrosis. So I've given you this chart, and when you're sitting there reading a high-risk CT, right, you can go through this to try to decide, what are we going to label this pattern? Are we going to label it typical UIP or probable UIP? And the only difference there is whether or not there's honeycombing. It can be indeterminate for UIP or maybe consistent with an alternative diagnosis. And even if you categorize it this way, what happens, 90% of these patients will have idiopathic pulmonary fibrosis, 80% of these patients will have idiopathic pulmonary fibrosis. Even if it's indeterminate for UIP on CT, 50% of those will still have idiopathic pulmonary fibrosis. And even if you think it's something else, 50% of those patients can still have idiopathic pulmonary fibrosis. Right? So what are those features that would lead you to an alternative diagnosis? If there's consolidation, extensive ground glass opacity, extensive air trapping, diffuse nodules or cysts. These findings, as we've discussed, can point you to an alternative diagnosis as opposed to UIP or idiopathic pulmonary fibrosis. Now that there are these drug therapies for idiopathic pulmonary fibrosis, so these drugs can be used for idiopathic pulmonary fibrosis or for other fibrotic lung diseases where the patient has progressive fibrosis. So it's not just IPF where they can use these drugs to treat patients with pulmonary fibrosis. And that's why it's important for us to decide if we think we're dealing with fibrotic disease, especially progressive fibrotic disease, progressive pulmonary fibrosis, versus inflammatory findings. So honeycombing, typical of UIP, if we see honeycombing. In this case, you wonder if there's honeycombing, maybe not sure, but we have peripheral coarse reticular opacities, we have traction bronchiectasis, so that's a probable UIP pattern. Here you have predominantly ground glass opacity with traction bronchiectasis. It's not particularly peripheral, so that points you away from idiopathic pulmonary fibrosis. And then here also there's extensive air trapping in this particular case, okay? And if there's extensive air trapping, even though it looks like there are fibrotic changes, you might want to suggest another disease as opposed to IPF. What's the other disease you might suggest here? What disease gives you lots of air trapping and fibrotic changes? Hypersensitivity pneumonitis, right? So if we see that, we want to make sure to bring up hypersensitivity pneumonitis, okay? So here's another patient who has peripheral opacities, reticular opacities. Here I'll show you the CT and a close-up on the chest radiograph. Tell me what you think. What complication of idiopathic pulmonary fibrosis does this patient have?
like a mass in the right lung?
Yeah, so this thing over here
Yeah.
turns out is a lung mass, right? So what's that going to be? Well, what do we say about these patients?
You get lung cancer?
Lung cancer, right? Typically adenocarcinoma. So this is a lung cancer in a patient with idiopathic pulmonary fibrosis. So you have to be on the lookout for that. Lung cancer is the third leading cause of death in patients with idiopathic pulmonary fibrosis. Okay. What complication of IPF is this? Pneumothorax, right? These patients develop honeycombing, peripheral opacities. Sometimes that can rupture into the pleural space, and the patient can develop a pneumothorax. So they can also develop larger cystic spaces as a result of the fibrosis, which also makes them prone to developing pneumothorax. This patient has idiopathic pulmonary fibrosis. 3 months later, comes in with worsening shortness of breath, and the CT looks like that. What's going on here?
Is it pulmonary?
What's that?
Pulmonary edema from the heart function?
Well, it could, so it looks like there's a lot of superimposed ground glass, right, in this patient. So one possibility is that, they could have pulmonary edema if they have cardiac decompensation. But what else will cause in patients with idiopathic pulmonary fibrosis the rapid onset of dyspnea and superimposed ground glass on their areas of idiopathic pulmonary fibrosis? Yeah, so it's an ARDS kind of like complication that occurs. What is that called? So not AIP, but exacerbation of IPF. Right? AIP is a different idiopathic interstitial disease. But in patients with idiopathic pulmonary fibrosis, a complication is to have superimposed ARDS or diffuse alveolar damage. So, and that is manifested by all this ground glass opacity and consolidation superimposed on the changes of pulmonary fibrosis. And histologically, it looks like ARDS, diffuse alveolar damage on these patients. So that's called acute exacerbation of IPF. All right, so this patient has shortness of breath. What does the CT show us? Does this patient have fibrotic lung disease? Or is this ground glass pulmonary edema? Or is this ground glass infection? Or is this a fibrotic lung disease?
There's a bronchiectasis. It looks like maybe some pleural sparing.
Yeah, so what kind of bronchiectasis is that?
Traction
Yeah. So there's traction bronchiectasis, right? And that's important. So there's traction bronchiectasis that tells us that there is fibrotic lung disease, okay? And it's predominantly ground glass. Is there honeycombing? No, there's no honeycombing. You said that you think that's subpleural sparing. So what pattern is this? Yeah, so this is an NSIP pattern. So the NSIP pattern does not have honeycombing. It has ground glass, can have peripheral distribution, and evidence of fibrosis, traction bronchiectasis, but no honeycombing. And subpleural sparing is a feature that is specific for NSIP. And just to prove to you that there's traction bronchiectasis, we can do this kind of reconstruction that shows you the distortion of the airways. What kind of reconstruction is that? That's a minute. So if you want to look for distortion of the airways, this is a nice way to demonstrate it. These minute reconstructions can show that to you. So this is an NSIP pattern. Now, it can be an idiopathic disease, but many underlying diseases, you don't have to memorize the list, but there are many diseases that can cause an NSIP pattern, including collagen vascular diseases, right? So it's very important to make sure the patient doesn't have some underlying connective tissue disease. So with NSIP, if it's idiopathic, or even if it's not, they can have progressive shortness of breath. This has more of an inflammatory component, so they can be treated with steroids. The 5-year mortality is less. The prognosis depends on the extent of fibrosis. So the worse the fibrosis, the worse the prognosis in these patients with NSIP. So here you can see that if it's predominantly cellular and inflammatory, they have very good survival. If it's fibrotic, the survival is poorer, although not quite as bad as UIP. So the prognosis depends on the extent of underlying fibrosis. So with the NSIP pattern, There's interstitial inflammation and fibrosis, but this is temporally homogeneous, meaning that as opposed to UIP, different areas of the lung are at the same stage of disease. So it's as if there was an episode of injury and the lung is reacting to that injury. And so it's temporally homogeneous as opposed to UIP, which is temporally heterogeneous with the NSIP pattern. Ground glass opacities, consolidations, reticular changes on the chest radiograph tends to have a basilar and peripheral distribution. The findings on CT, ground glass opacity, traction bronchiectasis, subpleural sparing, those are the findings that we see on CT. No honeycombing. Sometimes there might be honeycombing, but that's associated more at the fibrotic end of the spectrum with NSIP. So the more cellular it is, the more airspace opacities that you have. Traction bronchiectasis, and then here it looks like there might be some honeycombing and more traction bronchiectasis. Here you're more at the fibrotic end of the spectrum of NSIP. There can be an overlap. You can have NSIP that looks like UIP. You can have UIP that looks like NSIP. So in those cases, we're just not going to get it right when we come up with our interpretation of the disease. Cellular NSIP has more airspace opacities and ground glass, as opposed to fibrotic NSIP, which has less of that and more manifestations of fibrosis. So here you can see some nice traction bronchiectasis with surrounding ground glass. Notice still no honeycombing here, maybe some subpleural sparing in that case. Now, the approach, as far as we're concerned, to interstitial lung disease, the prior approach has been to decide if it's UIP or IPF as opposed to anything else. So is it UIP or is it not UIP? Now we're moving more towards deciding whether we're dealing with a fibrotic lung disease, especially is it progressing on serial examinations? Is it progressive pulmonary fibrosis versus anything else? Because patients with fibrotic disease, if we decide, this is where our interpretation becomes important. If we decide that it's a fibrotic disease, especially if we think the fibrosis is getting worse, those patients are candidates for antifibrotic therapy, regardless of what the underlying disease is, regardless if the underlying disease is IPF or if the underlying disease is some connective tissue disease. So biopsy becomes less important. What is important is, do we think it's predominantly inflammatory or do we think it's predominantly fibrotic? And if it is fibrotic on serial examinations, is that fibrosis getting worse? That now is becoming our role in terms of interpreting these patients with interstitial lung disease. So lung biopsy for interstitial lung disease is becoming less common. So that's what's important for us. Do we find inflammatory findings versus fibrotic findings? Because if it's predominantly inflammatory, those patients can be treated with steroids and immunosuppressions. As opposed to fibrotic disease, those patients are treated with antifibrotic agents. And is there progressive pulmonary fibrosis? Is the fibrosis getting worse? What are CT findings of inflammation? Ground glass. That's a finding associated with inflammation. Consolidation, right? Those are findings associated with inflammation. Nodules. Here you have a nice distribution of nodules in this patient, right? What do we think this patient might have? Sarcoid, yeah. So especially perilymphatic nodules. So these are all findings associated with inflammation. So if they wanted to treat this patient, they would treat with steroids or immunosuppressives, as opposed to findings of fibrosis. What are findings of fibrosis on CT? Irregular reticular opacities, especially in the periphery, traction bronchiectasis, honeycombing, right? These are all findings of fibrosis. If this is getting worse on serial CT scans, those are patients, regardless of what their underlying disease is, those patients are candidates for being treated with antifibrotic therapies. Okay? So what do we see with progressive pulmonary fibrosis, with fibrosis that's getting worse, or what is it that we look for to say that there's progressive pulmonary fibrosis? We look for worsening of fibrosis in previously affected lung. We look for new areas of fibrosis, pretty obvious, right? That's what we look for. So here's a patient with ground glass and traction bronchiectasis. Their follow-up CT shows the traction bronchiectasis is worse. It shows worsening disease here in the periphery, there in the left lower lobe. So this patient would say has progressive pulmonary fibrosis. So with these findings now, this patient would be a candidate for antifibrotic therapy. And this is becoming our role in terms of interpreting these cases. Okay? So now what's the role for artificial intelligence, quantitative imaging for ILD? Is there a way to give numbers? Is there a way to objectively quantify how worse is the disease? Well, there are this software that's now available that will analyze your CT scan, find areas that are ground glass, and here they're labeled in yellow, areas of reticulation labeled in blue, areas of honeycombing labeled in pink. It will score it, give you, a percentage, and now using that, you can quantify it if you choose. There's another example, normal, there's your color coding, and there it is on the CT. And it can quantify it, follow it on serial CT scans. So if you choose to, you could actually give numbers, how much of the lung, what percentage of the lung is involved with honeycombing, and comparing serial CT scans, what has got worse, has the percentage increased or decreased. And this is out there now, so these are now commercially available, this capability, and that's quantitative imaging for interstitial lung disease. Okay? So any questions for what we've covered up to now? Here, so what do we have here? Who wants to talk about this?
You have bilateral peripheral consolidations.
Yeah, so that's the key finding, is that you have airspace disease, but the distribution of the disease is that it's peripheral, right? So given that distribution, if we're in the category of these idiopathic interstitial pneumonias, the one that we talk about is what?
Organizing.
Yeah, so organizing pneumonia, if it's idiopathic, it's called
Cryptogenic.
cryptogenic organizing pneumonia. Now, organizing pneumonia itself is a reaction to lung injury. So you can see organizing pneumonia associated with all kinds of other things. And the key about this is that if you make the diagnosis, organizing pneumonia is responsive to steroids. So that's the key about suggesting the right diagnosis here. Okay? You can see the difference before and after, how the consolidations clear pretty quickly. So cryptogenic organizing pneumonia, there have been other names for this. Originally it was called BOOP, but because that gets confusing with bronchiolitis obliterans, which is a completely different disease, that's been dropped. So organizing pneumonia is the preferred term. And if it's idiopathic, it's called cryptogenic organizing pneumonia. And then here's some other terms that have also been associated with this. Now, the issue with organizing pneumonia is that it is primarily a disease of the air spaces. So it starts with disease in the air spaces that secondarily you get these fibrinous plugs that get into the small airways. And that's where we get the bronchiolitis obliterans part in the pathologic description. So bronchiolitis obliterans with organizing pneumonia. So the organizing pneumonia actually starts in the alveolar air spaces and then secondarily invades the small airways, these granulation tissue polyps. And so on histology, there are these granulation tissue polyps that will invade get into the small airways from the air spaces, and that's the bronchiolitis obliterans part that the pathologist sees. But the disease itself is primarily centered in the air spaces. Temporally, there's temporal homogeneity, the architecture tends to be preserved. That pathology can be seen with many, many things. It's a response of the lung to injury. Not important to memorize the list, but the point is that just about any type of injury you can think about to the lung, one of the response patterns to that can be organizing pneumonia. So the finding of organizing pneumonia on pathology is kind of nonspecific in terms of what the underlying disease can be. So since organizing pneumonia can be found associated with many diseases, the presence of it on a transbronchial biopsy is only of limited value without clinical and radiological correlation. So COP, the idiopathic form, has an onset with cough, progressive shortness of breath, low-grade fever, consolidations. It looks like pneumonia. And many times the patients are treated for pneumonia. They don't get better. The story is you do a CT scan, you notice the peripheral consolidations, you suggest the diagnosis, they treat with steroids, patient gets better. Okay? So the key finding is the distribution of these consolidations, that these are predominantly peripheral in distribution. So that's why this belongs in our differential for peripheral consolidations. It might also have a parabronchiolar distribution around the airways, so that you might also see. So we can see consolidations in the periphery, like you see here, but also they might also be parabronchiolar around the airways, like you see in that particular example. Okay, there is a sign that in the literature has been associated with organizing pneumonia. The sign is called atoll sign. The other term for this is
Reverse halo.
reverse halo, right? So what's the difference between the halo sign and the reverse halo sign?
Like reverse halo is the where you have like the ground glass opacities in the center, right?
Yeah, so basically with the halo sign, the ground glass or the less dense part of the opacity is in the periphery. That's the halo sign. So the halo is the less dense part, the ground glass part. With the reverse halo sign, that less dense portion, the ground glass portion, is more towards the central region of the opacity. And the periphery of the opacity is denser than the central portion of the opacity. So it's not cavitation, right? It's still ground glass opacity. But that is the reverse halo sign. So in the literature, this has been associated with organizing pneumonia. As it turns out, though, that the reverse halo sign is a very nonspecific sign, and so it's not really pathognomonic for organizing pneumonia. Around here, we have seen the reverse halo sign, particularly with two particular disorders, besides organizing pneumonia. The two disorders that we see reverse halo sign with, anybody?
Pulmonary infarct.
Yeah, pulmonary infarct. So you will see it, it won't be round, right? It'll be in the periphery in wedge shape, pulmonary infarct. The other thing is a particular infection. Aspergillus, yeah. So aspergillus is also associated with reverse halo sign. So many other things can also do it. So it's not specific, but know that it is associated with organizing pneumonia. So when it was first described, it was postulated that it might be specific for it, but as it turns out, it's not. It's not specific for organizing pneumonia or COP, but it can be seen with it, right? So something to remember. Another pattern we can see with organizing pneumonia or even cryptogenic organizing pneumonia is this so-called perilobular pattern, where you have thickening around the secondary pulmonary lobules, but it has this kind of strange appearance. So remember, the most common cause of interlobular septal thickening is what? Pulmonary edema or interstitial edema, and that tends to be very smooth and very regular, but this has this kind of irregular appearance. Also, like a nodular thickening we can see with sarcoid or lymphangitic carcinomatosis, but here it's got this strange kind of thickening that's not uniform. It doesn't look like any of those other things, but this is also described, this perilobular pattern is also described for cryptogenic organizing pneumonia. So consolidations increasing over several weeks despite antibiotics, predominantly parabronchiolar or subpleural consolidations on CT. That's what should make you consider this entity. And then here's another example, consolidations here, somewhat peripheral, subpleural. We suggested organizing pneumonia, they treated with steroids, and you can see afterwards that there was a marked improvement in the appearance of the consolidations after treatment. Okay, so moving on, if I tell you this patient presents with shortness of breath, requires intubation, shortly thereafter, there's the appearance on CT. Which of the idiopathic interstitial pneumonias are we talking about here? So this is the appearance of ARDS, where you have the rapid onset of consolidations. The feature on the CT that might be associated with ARDS is what? There's septal thickening, there's ground glass, but what is it about the appearance that is kind of typical? Yeah, the dependency, right? So that gravitational gradient where it's worse in the posterior part of the lungs. So with ARDS, a lot of the opacity that we see is also atelectasis. The lungs get very stiff with ARDS. So in the supine position, you will see that the dependent portion of the lung tend to have increased opacity. So So this is ARDS, but idiopathic ARDS, the idiopathic interstitial pneumonia, is called what?
AIP.
AIP, right, acute interstitial pneumonitis. So that's essentially that represents idiopathic ARDS. So it first described by Ham and Rich, the Ham and Rich syndrome in 1944. Originally it was thought to be an accelerated form of IPF or UIP, but it turns out that's not the case. It is a completely separate disease. So it probably results from a single episode of lung injury by some unknown cause that results in ARDS. So it is essentially ARDS of unknown cause. So comparing AIP with UIP there are foci of injury, and then it's ongoing. There's ongoing injury and repair. So you will find the lung at different stages of injury and repair when you examine it. Whereas with AIP, there's massive injury at one time, as with ARDS, and that can then transition to a fibrotic phase, as you know, we've gone over with ARDS also. So it's one episode of injury. And the difference in terms of the fibrosis that you see is also different. With UIP, the fibrosis is interstitial. So there's interstitial thickening as the fibroblasts accumulate in the interstitium and cause fibrosis. With ARDS, because of the spillage of the protein-rich contents into the alveolar air spaces, it's that part that becomes incorporated into the alveolar walls. So the fibroblasts start proliferating actually in the alveolar air spaces, and then you get fibrosis by accretion. So it's organization of the contents that have been spilled into the air spaces that get incorporated into the alveolar walls. So just like ARDS, you might have cough, fever, shortness of breath, rapid progression to severe shortness of breath and respiratory failure. It has a very high mortality. As you know, we've gone over the histology of ARDS, so obviously this is going to be the same, the exudative phase where everything is spilled out into the alveolar air spaces, and then a proliferative phase, type 2 pneumocytes, and then a fibrotic phase where that stuff becomes incorporated into the alveolar walls, and then in the fibrotic phase you wind up with thickening of the alveolar walls and the interstitium. That's a continuation of the thickening here from fibrotic phase of ARDS. Rapidly progressive, starts out as consolidations, gets worse, so no different than ARDS. And we've talked about the distribution of the opacities, that gravitational distribution where if the patient's lying on their back, it's going to be worse in the dependent portions of the lungs. Okay? When we get healing, when you start to get fibrosis, you can see traction bronchiectasis, so you see the opacities around irregular airways. So when you start to see that, then that's the fibrotic phase. You're in the fibrotic phase of disease when you start to see the traction bronchiectasis. There is no honeycombing with this, so we don't get honeycombing with AIP or ARDS. The key here in this particular case is the history. So I tell you, there's a 48-year-old smoker. We're talking about idiopathic interstitial pneumonias. We have the findings. So what's the finding? What's the underlying disease? So how would you characterize the abnormality here? What would you say? Yeah, so we have ground glass opacity as the abnormality. The distribution, is it central or peripheral? Yeah, somewhat more peripheral, right? Okay. And with that distribution, ground glass opacity, somewhat peripheral, somewhat mosaic attenuation, and you're also going to see that. The key history is the patient is a smoker. So which of the idiopathic interstitial pneumonias is this going to be? This is going to be what? Can't hear you. Yeah, DIP. By the way, what do you have to tell me about that term, DIP? What does that mean, desquamative interstitial pneumonitis? What does that term mean? That the term itself, desquamative interstitial pneumonitis, means that when we use that terminology, we're implying that the abnormal opacity is from what?
Pneumocytes. The pneumocytes is
Desquamated
pneumocytes.
pneumocytes, right? Desquamative interstitial pneumonitis, right? So that implies that the opacity is from desquamated pneumocytes. Is that correct?
The macrophages.
Yeah. So in the naming of this was a misnomer, that when Lebo was naming the interstitial pneumonias, under the microscope, he thought that the cells that he was seeing within the alveolar air spaces were desquamated pneumocytes. It turns out that that's not correct, that the cells are alveolar macrophages that accumulate within the air spaces. So we'll talk about this much later in the course of the lecture, but this disease, now there's a proposal that will probably be officially adopted to rename the disease as alveolar macrophage pneumonia, so that the name of the disease characterizes exactly what we're talking about. So DIP, what we see, the ground glass opacities are because of all these cells. So this occurs in smokers, and what happens is that these cells become recruited and fill the alveolar air spaces. It turns out that these cells turn out to be alveolar macrophages. So alveolar macrophage pneumonia is the more accurate terminology for what we're actually dealing with here, as opposed to DIP. And so DIP is a misnomer. There really isn't that much fibrosis. Tends to be a temporally homogeneous disorder. So these desquamated, these alveolar macrophages, they tend to be pigmented, which is pigmented macrophages are what is seen in smokers. So it's associated with smoking. It's a reaction of the lung to cigarette smoking, much less likely than IPF to progress to fibrosis. And if it can be treated with steroids, or if the patient stops smoking, has a very good prognosis. So that is DIP. What do we see on chest radiographs? Kind of opacities, basilar, peripheral. Usually you don't see much because these are ground glass opacities. Preserved lung volumes on CT, ground glass opacity, somewhat of a peripheral distribution. You might also have this mosaic attenuation, areas of air trapping. Remember, these patients are smokers, so we might see that also. We usually don't see honeycombing, so there's no honeycombing, not much fibrosis associated with DIP. And so here's an example, ground glass opacity, 4 months after treatment, it gets better, so this is very responsive. Same idea though, here we have a 48-year-old smoker with shortness of breath. Which of the idiopathic interstitial pneumonias is this? They are symptomatic, right? And that's all right. So tell me about that. So the answer is yes. So RBILD, respiratory bronchiolitis ILD. So the point you're asking me, they're symptomatic. Why? Why is that important?
Because otherwise it's just RB.
Yeah. Otherwise it's just RB, respiratory bronchiolitis. So and the respiratory bronchiolitis, as the term implies, is inflammation around the respiratory bronchioles, right? So what constitutes that inflammation? What is it that's accumulated around the respiratory bronchioles?
Lymphocytes? Is it like lymphocytes?
No.
Also macrophages?
Also alveolar macrophages. So this is along that same spectrum, right? So you can group these together. The difference is just the distribution of the alveolar macrophages. Again, this is related to smoking also. So when the alveolar macrophages accumulate in the air spaces predominantly, and we get the ground glass opacity, we call that DIP. When it accumulates around the central lobular bronchioles and you get the central lobular distribution of ground glass opacity, we call it respiratory bronchiolitis. If the patient is symptomatic, then the disease is respiratory bronchiolitis ILD, interstitial lung disease. Respiratory bronchiolitis, this pattern itself you can see in smokers. They don't necessarily have to be symptomatic. If you look carefully, and sometimes you'll notice this on our CT scans of heavy smokers, lung cancer screening, you might notice that there are these kind of areas. It's rather subtle, but there are these areas of central lobular ground glass opacity. So, and so respiratory bronchiolitis is a common finding both on imaging and also in pathology in smokers. They don't have to be symptomatic. The other disorder that can give you central lobular ground glass opacities that you will consider is what? Yeah, hypersensitivity pneumonitis. But if I give you this history, will you consider hypersensitivity pneumonitis? Yes or no? I give you that history, I give you that CT scan. Is this HP? Yes or no? Would this be
It's
HP?
less likely.
Why?
I mean, it's usually like organic exposure, organic exposure, right?
There's another important reason. Anybody?
Hypersensitivity would be like eosinophilic mediated.
Can't hear you.
The hypersensitivity will be eosinophilic mediated, not much.
I still can't hear you. Please
So it'll
speak up.
be eosinophilic mediated.
It's like.
Does that make a difference in the appearance?
Just the laboratory.
The answer is smokers don't get HP. Oddly enough, smoking is protective against HP, hypersensitivity pneumonitis. Smokers don't get HP, right? So if you get the history of smoking and you have central lobular ground glass nodules, you go to respiratory bronchiolitis, okay? So RBILD, that's when the patients are symptomatic, again, related to smoking, mild shortness of breath. This also resolved with SIRS. By the way, this is more common than DIP, right? So this is much more common than DIP. So we will see then these macrophages accumulate within the airways and also around the airways, right? That's why you'll get that. So the inflammation is centered around the central lobular bronchioles. That's why you have central lobular ground glass opacities. It tends to be temporally uniform. So they're probably the same spectrum of disease. With DIP, you get the pigmented macrophages in the alveolar air spaces. That's where they predominate. With RBILD, they will be within the central lobular bronchioles or around the central lobular bronchioles also. If they happen to do bronchiolar lavage in these patients, they will see the pigmented macrophages in the bronchial alveolar lavage fluid. So that's another way to make the diagnosis, just to look for that. The so-called smoker's chest, where you have this kind of interstitial pattern, is probably a reflection of respiratory bronchiolitis, what's been called the smoker's chest on chest radiograph. Central lobular ground glass opacities can be very subtle, so you have to look really hard for them. They are smokers, so you might also see these areas of central lobular emphysema. Okay? And you can't diagnose this without biopsy, as I've said. If you see those smokers' macrophages within the BAL fluid, then that's also sufficient to make the diagnosis. Example of when the patient is symptomatic, 2 years later, gets better. So if the patient stops smoking, it can also be treated with steroids. Okay. The findings, the findings here. Who wants to discuss the findings here?
There's like many nodules,
There are many nodules, yes.
and there's cysts also.
That is correct, right. So you have nodules and cysts. Now, we've said that the approach to the micronodular pattern on CT is what's the first thing you want to decide?
Like the distribution.
The distribution. The three distributions we consider are
There's like perilymphatic,
two more.
peripheral.
No, not peripheral.
Random.
Perilymphatic, random, and
Central lobular.
central lobular, right. So what do? We first decide if,
For contact pleura.
yeah, are the nodules touching the pleura? Are there nodules in this case touching the pleura?
Yeah.
Yeah, there are some. So that leaves what two distributions?
Perilymphatic and random.
Yeah, so perilymphatic and random. And for this particular case, it might be a little difficult trying to decide between those two. But if you had to pick one, which would you pick?
Could pick perilymphatic.
Yeah, especially here, you can see that the nodules are nicely outlining what? What are they outlining? A secondary pulmonary lobule, right. So perilymphatic nodules with cysts. Which of the idiopathic interstitial pneumonia?
LIP.
LIP, right. So lymphocytic interstitial pneumonia. So that's LIP. This is pretty rare, actually, especially as an idiopathic disease. There's some controversy whether it really exists as an idiopathic disease. It's more often seen with other diseases, right? So the LIP pattern, if we find it or we suggest it, is most often associated with other underlying, like autoimmune types of diseases. So what are some of those diseases that are associated with LIP? Well, the two major ones are what?
Sjogren's?
Sjogren's, right? Sjogren's is one. Another one is
Lupus. Lupus.
not so much HIV, right? So HIV is also associated with this pattern. So those two, but especially Sjogren's. So autoimmune disorders, here's a list of them, but HIV and Sjogren's are the two big ones to think about. Controversy whether it really exists as an idiopathic entity. So if we find it, we should look for underlying diseases. So in the vast majority of cases, LIP is secondary to something else. So it can, present with shortness of breath, et cetera, et cetera. Does it have malignant potential? Seems to have some malignant potential in patients with Sjogren's. Does it have malignant potential with HIV? I'm not so sure. Okay. The key is lymphocytes in the interstitium. And the difference between this and lymphoma is that here they're polyclonal lymphocytes. All right, so it's proliferation of lymphocytes in the interstitium with LIP. That's what we have. The appearance is very variable. You can have reticulonodular pattern, you can have alveolar pattern, you can have mixed opacity. So the appearance is very nonspecific. Here's an example with nodules, somewhat larger nodules. You can have that. The most specific finding really for LIP is the cystic disease, right? So LIP is one of our differentials for cystic lung disease, if we see it. So lung cysts, if we see cysts, then think about LIP. Here's some examples. Here's ground glass opacity with cysts. So LIP can give you ground glass with cysts. Here is mostly cystic there. Here's an example with ground glass and cysts treated with steroids. The ground glass got better, but you can see the background cysts there. More examples, ground glass opacity, predominantly cysts, ground glass and cysts. Right? So cysts are the most important or the most really specific finding for LIP. Okay. What about this case? What do we have here? So you have these apical subpleural opacities. You said it's fibrosis. How do you know it's fibrosis?
I mean, it looks like there's a little contraction.
Yeah, so there's architectural distortion, right? And when you look at the airways, you also have what?
Like traction bronchiectasis.
Traction bronchiectasis, right? So you have this apical distribution, especially subpleural, apical upper lobe distribution of fibrotic change, right? Leaving aside idiopathic interstitial pneumonias, if you're giving a differential for this, what would you start with? What?
Well, no.
You might suggest TB, although what goes against TB? It's symmetrical, right? It's very symmetrical, right? But TB certainly is in your differential for upper lobe fibrotic disease. What else?
It's like pneumonitis, like chronic.
Yeah, but for HP, you would look for other things, right? What are the other things you're going to look for HP?
Nodularity.
You look for nodules, right? You'd also look for what? HP, you'd look for, important finding with HP is emphysema, air trapping, especially in the chronic stages, right? So you look for air trapping and emphysema for HP. So if you have fibrotic disease with a lot of emphysema, HP is always in your differential diagnosis there, okay? But symmetric upper lobe fibrotic disease, the first thing on your differential is what? Sarcoid, of course, right? So the first thing on your differential is going to be sarcoid when you see that. But for the idiopathic interstitial pneumonias, that's the category, this is actually quite rare, and you're very unlikely to make this diagnosis prospectively, okay, because you're going to think about other things first. All right, so what's the answer for idiopathic interstitial pneumonias? This one is, it's actually the one that's most recently been described a number of years ago. No, silicosis is not an idiopathic interstitial. By the way, what goes against silicosis? Silicosis does give you upper lobe fibrotic disease, but what goes against silicosis here? Doesn't give you plaques.
I caught myself.
What goes against silicosis?
The lymphadenopathy?
What?
The lymph nodes?
You don't have eggshell calcifications. You don't have to have that, though. But what really goes against silicosis?
It's in the lower lobes.
Silicosis is upper lobes. Nodules, right? Silicosis has nodules, small nodules, right? That goes against silicosis. The disease, have we mentioned the disease yet? No. It's 4 letters. You want to mention the letters? Oh, it's nice that everybody does the studying before conference. PPFE, right? Pleural parenchymal fibroelastosis. What's that? What'd you say?
I just said there's an I.
There's an I.
Because you said I, right?
You know the idiopathic.
It's idiopathic pleural parenchymal fibroelastosis, PPFE. Right? So that's idiopathic. Fine. Anyway, here you go. Upper lobes can be associated with pneumothorax. Very rare. You're very unlikely to make this diagnosis prospectively. But it is there, and if you're asked, you know, upper lobe subpleural distribution of fibrosis, which idiopathic interstitial pneumonia, that's the one. Okay? So in terms of these, IPF, honeycombing, reticular, peripheral, subpleural, basal, concentrate on, it's so confusing, right? You have this alphabet soup, but think about what are the differences, right? NSIP, ground glass opacity, reticular, traction bronchiectasis, basal, subpleural sparing is the most specific feature associated with NSIP. No honeycombing with NSIP. You get traction bronchiectasis and ground glass opacity. COP, we've talked about peripheral consolidations. They can be subpleural, they can be peribronchial. This is airspace disease. AIP, ARDS, idiopathic ARDS. DIP, ground glass opacity, tends to be basal, subpleural, peripheral distribution, RB-ILD, central lobular ground glass. LIP, the cysts. You can have nodules, you can have peribronchial thickening, you can have ground glass, very non-specific, but the cysts are the most specific finding associated with LIP. And PPFE, it's the distribution of fibrosis, the subpleural apical distribution, that is most specific for PPFE. So, when we look at this case, okay, I will give you a choice. You have COP, NSIP, UIP. Which of those would you pick?
Not SIP.
All right, why not NSIP?
There's subpleural bulge.
Well, you don't have to have subpleural sparing with NSIP. It is specific for NSIP, but you don't have to have it, right? But what would you look for NSIP? For NSIP, you look for ground glass, peripheral distribution associated with traction bronchiectasis. Is that what we have here? Yes or no? Okay, so the answer is no, not NSIP. For UIP, what would you look for? Honeycombing, but if you can have UIP without honeycombing, there you would look for you guys are short-term memories. Reticular peripheral opacity is associated with fibrosis, traction bronchiectasis. Do you have that?
No.
All right, so by process of elimination, we're down to, right, but what is the finding here that's associated with COP? The peripheral distribution, right? You have airspace opacities in a peripheral distribution, okay? So of the 3 choices, right, COP is the one that fits the best. Okay. How about this case? Let's give you those. Now you have traction bronchiectasis. You think they're subpleural sparing. What are you going to go with? Yeah, so here you go. You see how easy this is? So here you go with NSIP. Okay. How about this one?
There's honeycombing.
I know, but tell me, you got to earn the option, right? Now you have what?
Honeycombing.
Now you have honeycombing. The distribution of disease is peripheral. So here you go with,
UAP.
right, see how easy this is, right? They're all the same patient. So this is the initial CT. This is 2.5 years later. This is 5 years later. So we start with organizing pneumonia, goes to NSIP, goes to UIP. This is not uncommon. Okay, so with these interstitial lung diseases, you can see this progression of disease. So these patients can start with a picture of organizing pneumonia that then progresses to what looks like NSIP and then progresses to UIP. So sometimes it just depends when you get them, when you catch them, okay? When you get them here or when you get them earlier, all right? So now we'll get to talk about pulmonary fibrosis, other diseases besides the idiopathic interstitial pneumonias, all right? What do we think about this? Yeah, so there is fibrosis. The distribution is peripheral and basilar. Yes, so is this UIP? Well, it is a UIP pattern, but is this idiopathic pulmonary fibrosis? I gave you a second image there for a reason. Okay, so what is this? This is asbestosis, right? So asbestosis can also give you fibrotic disease in a lower lung distribution, can look just like UIP. The key is there asbestos exposure? We have the calcified pleural plaques that tells us there's asbestos exposure. So here it's asbestosis. We're not going to say IPF for this case. Pulmonary fibrosis with asbestos exposure is asbestosis. There are other causes, though, of fibrosis that can be identical to UIP on CT scan. Could be asbestosis. This one is big, collagen vascular disease, especially scleroderma and rheumatoid arthritis. That essentially gives you the same changes as UIP. That is UIP. Even the pathologist would say it's UIP. IPAF, this is interstitial pneumonia with autoimmune features. That means you have an interstitial lung disease with some features of some systemic autoimmune condition, although it's not completely diagnostic of some autoimmune condition. So they have some underlying problem, some form of maybe seronegative rheumatoid arthritis, but some underlying autoimmune problem, and they develop fibrosis. That is IPAF. Drug reactions, and you must always exclude hypersensitivity pneumonitis whenever you're dealing with fibrotic lung disease. Asbestosis from inhalation of asbestos. The macrophages try to ingest them, they die, they release their fibrogenic substances, enzymes, and that's what results in fibrosis within the lungs with asbestosis. So on histology, for definitive diagnosis, they actually look for the asbestos fibers. Okay. You want history of asbestos exposure, restrictive lung disease, abnormal chest X-ray, or abnormalities on the CT. But of course, you want the history of asbestos exposure. On X-ray, interstitial changes, mid to lower lung distribution. Of course, for early disease, chest X-ray is not going to be very good. Later disease, you will see some widespread interstitial disease, but we will find it much earlier on CT. Of course, CT is going to be much more sensitive. Normal high-res does not exclude asbestosis, but high-res CT can be performed prone and supine for very early disease. You might want to do it prone, especially if the chest X-ray is negative. The distribution of disease, posterior subpleural distribution, findings of fibrosis, curvilinear subpleural lines, parenchymal bands. Of course, evidence of exposure is when you have the pleural abnormalities. These dot-like subpleural opacities, this patient is prone, by the way, so these dot-like subpleural opacities are the earliest findings associated with asbestosis. So to see this, you probably would have to scan the patient prone to be able to differentiate this from dependent atelectasis. So in very early cases of asbestosis, if you're looking for it, you might want to scan the patient's prone. Okay. More examples here, early changes, scanning the patient prone, you see the distribution of disease. So that is a feature of asbestosis, that subpleural posterior distribution of these abnormalities. When it progresses, then you can get honeycombing, peripheral reticular opacities, irregular peripheral reticular opacities. So those are, it looks like UIP, okay, when it progresses, with traction bronchiectasis also. So here we have some subpleural lines, right? You can see that with asbestosis also. These are parenchymal bands. So subpleural lines, these are just descriptive terms. Subpleural lines run parallel to the pleural surface. Parenchymal bands run perpendicular to the pleural surface. So these are parenchymal bands that can also be seen with asbestosis. Pleural calcification. If we see that, then we know that there's been exposure to asbestos. If we have any interstitial lung disease, then we can pretty much assume that that represents asbestosis. That might be very subtle, so you have to look really hard, okay, for the pleural calcifications in cases of asbestosis. Pretty easy to determine. This is fibrotic. You have traction bronchiectasis. Here you might have some honeycombing over there. But look at the pleura very carefully. Okay? The plaques, especially over the diaphragm, it's a very common location to get these pleural plaques that tells you that the patient has had exposure to asbestos. This does not mean asbestosis. This means exposure to asbestos. If there is interstitial lung disease after exposure to asbestos, that is asbestosis. Okay? So don't confuse the two. This patient is short of breath. Besides the big heart, we have some interstitial opacities in the lower lung distribution. But I will give you this close-up. Tell me if you notice anything.
Micronodules?
What?
Micronodules?
Micronodules? No. No, we don't notice anything? All right, let's move on. Here's the CT. What do we think is going on in this patient? Why?
This esophagus is like.
There you go. And this is a board favorite, right? Dilated esophagus with interstitial lung disease, you go with scleroderma. Let us go back to the close-up. What do you see? Now the heads are nodding. Yes. Here's the trachea, here's your dilated esophagus. Okay? So dilated esophagus associated with interstitial lung disease, scleroderma. So underlying connective tissue diseases are also associated with pulmonary fibrosis and interstitial lung disease, right? So here's the hand in this patient with scleroderma. Right? We have resorption of the DIP joints, that destruction of the DIP joints, which you can see with, the DIPs itself, not the joints, that you can see with the distal phalanges, right? So this patient also has interstitial lung disease, shortness of breath. What's our diagnosis here? Now we can go through the whole thing. UIP. Oh, okay. What is it?
That left shoulder looks pretty,
How about the right shoulder?
I can't really see, oh, no, I can see, it's also previous stuff, so it's like maybe rheumatoid.
This is rheumatoid arthritis. Yeah. So with rheumatoid arthritis, it's bilateral symmetric disease. Okay. So you have narrowing of both shoulder joints, interstitial lung disease. This is rheumatoid arthritis. There's the hands. So this also can give you a UIP pattern. Honeycombing, subpleural distribution of fibrotic disease. So underlying, if patients presenting with pulmonary fibrosis, they have to rule out underlying connective tissue diseases. So rheumatoid and scleroderma are very commonly associated with them. Scleroderma tends to give you an NSIP pattern. Rheumatoid tends to give you a UIP pattern. Less common patterns in others, SLE, DPH, DAD, and then, I've listed some of these others. Also, organizing pneumonia, you can also see that as a manifestation of underlying connective tissue diseases, right? There have been some proposals. How can you differentiate fibrosis of connective tissue disease from IPF on CT? There have been these signs that have been described. The anterior upper lobe sign, exuberant honeycombing sign, straight edge sign. So I've given you the definition of these. So the anterior upper lobe sign, concentration of fibrosis in the anterior upper lobes with relative sparing of other parts of the upper lobes, although the lower lobes are also involved, right? So these are all more common with connective tissue disease as opposed to IPF. That's the upper lobe sign. Exuberant honeycombing sign, extensive honeycombing, cysts greater than 70% of the fibrotic portion of the lung. Okay, that's the exuberant honeycombing sign. Here's straight edge sign, isolation of fibrosis to the lung bases without substantial extension along the lateral margin on coronal images. So on coronal, you see that sharp demarcation between the fibrotic, these areas of honeycombing, and the rest of the lung. So in this case, the underlying disease is oh, don't tell me I got you again. What is this?
Scleroderma.
Scleroderma, dilated esophagus, interstitial lung disease, scleroderma. Right? So these findings are associated with connective tissue disease as opposed to idiopathic pulmonary fibrosis. Right? You must always differentiate hypersensitivity pneumonitis from any of these diseases that we've talked about. So if you have extensive regions of air traffic associated with interstitial lung disease, make sure that you bring up the possibility of hypersensitivity pneumonitis. Drug reactions, there are all these drugs that can also give you interstitial lung disease. It's important to know, is the patient taking any medications, especially if the patient has a history of cancer? Are they taking any medications, any of these checkpoint inhibitors related to that? The ILD patterns associated with drugs. So these are acute, subacute patterns. Patients tend to be much more symptomatic here. And all except the ARDS pattern in UIP may respond to steroids. Organizing pneumonia, that pattern is very responsive to steroids. More fibrotic patterns like NSIP and UIP, you can also see that with drug reactions. Okay, this is pulmonary fibrosis from nitrofurantoin. There's the CT scan showing you the interstitial disease. This is chemotherapeutic agent, so it's very important to get the history of what medications is the patient getting. There's a CT showing you that. So the CT itself is not going to be very specific. There's bleomycin toxicity, peripheral distribution of particular opacities of ground glass. Sarcoid tends to give you an upper lobe distribution of disease, but there can be cases of sarcoid where it is more lower lobe. That's unusual, but it can occur. Sarcoid can do that. What are the findings here, and what do we call this? So here we have, what are the findings? These aren't cysts. These are what? They're not thick wall. These are bulli. Right? These are bulli associated with honeycomb. So this patient is a smoker, right? This patient is a smoker who's developed COPD and fibrotic lung disease. There is a term for this. It's called CPFE, combined pulmonary fibrosis and emphysema. So you might see this combination of patients with extensive emphysematous change who also have changes that look like IPF or UIP. So this can be seen in smokers, and it's termed combined pulmonary fibrosis and emphysema. So we can see that also. Honeycomb lung, any end-stage disease will give you honeycomb lung. Okay? So honeycomb lung is when we have extensive fibrosis throughout the lungs. I've listed all these diseases. Any of these diseases can result. Any disease can give you honeycomb lung. So if we have a lower lung distribution of fibrotic lung disease, here is the way you think about it. These are the things that you think about in terms of what entities give you fibrosis. Remember, though, that on the chest X-ray, lymphangitic spread of tumor and bronchiectasis can also look like interstitial lung disease if you're looking at a chest X-ray, so remember that. But these are the most common fibrotic diseases, things that you should think about in your differential diagnosis. For those of you that like mnemonics, there's a nice mnemonic for you. You can memorize all of that if you want. Okay? This is peculiar because what? It's unilateral. What's your differential for unilateral interstitial lung disease? Radiation, right? But we usually wouldn't radiate the whole lung, but that is a thought, right? Radiation can give you localized, right?
Lung transplant.
Can't hear you.
Lung transplant from the other side.
Yeah, which lung was transplanted?
Right.
So what's the clue?
The
Surgical marker.
There's a surgical clue. So this is a lung transplant. Right? So they will transplant, so this is the healthy lung, right? So both lungs look like that at one point. They transplanted this lung. This is the lung transplant. This is the transplanted lung. Right? So that's a lung transplant. Differential for unilateral interstitial disease, reperfusion pulmonary edema. We've covered that before. That's unilateral pulmonary edema, lymphangitic carcinomatosis, radiation therapy, lung transplant. Okay? Look for ancillary findings because that can give you some specificity. Pleural plaques, dilated esophagus, lymphadenopathy, right? Of course, the clinical information is the most important. Are we done with interstitial lung disease? No. Because, as it turns out, in December, they came up with an updated classification of interstitial pneumonias. So all of this has not really been officially adopted by the various societies. So as far as what you need to know for the core exam, go with everything that we've covered, the way we've classified it and what we have gone through. The next time I give this lecture, though, it will be different. As they adopt these, let me just go through some of the changes. And my personal opinion is that they really messed it up and made it much more complicated than it needed to be, but let's go through it. Extension beyond idiopathic interstitial pneumonias to include secondary causes. Now they've lumped everything with interstitial lung disease, new categories and updated terms. They've separated interstitial versus alveolar filling disorders. I mean, we've always done that. I mean, we've talked about that already. But they've also divided interstitial disorders. They can have fibrotic forms and non-fibrotic forms. We kind of talked about all that too. And some consideration of diagnostic confidence in patient evaluation and management. So instead of idiopathic interstitial pneumonias, we now have interstitial pneumonias. And it includes the idiopathic causes and all of the non-idiopathic causes like connective tissue disease, hypersensitivity pneumonitis, medications, inhalation, all of that stuff. So they kind of lumped it all together. New subcategories, they've introduced this new category, BIP. Essentially, this is hypersensitivity pneumonitis, or an appearance that looks like HP, hypersensitivity pneumonitis, but in most cases, it will be from exposure to extrinsic antigen, although this pattern might be also seen with connective tissue disease, aspiration, and drugs. And they've called this pattern, they've given it this name, BIP, bronchiocentric interstitial pneumonia, meaning that the predominant fibrotic pattern is centered around the airways. The inflammation is around the central lobular airways, which is what you see with hypersensitivity pneumonitis. AIP, renamed as idiopathic diffuse alveolar damage, right? Essentially ARDS. Yeah, you want the I before it. DIP, I warned you about this, renamed as alveolar macrophage pneumonia. Those are the changes. So these interstitials, so these are now categories. The interstitials can be broken up into fibrotic or non-fibrotic. UIP is fibrotic. NSIP, we've talked about, can be fibrotic or non-fibrotic. BIP, think about hypersensitivity pneumonitis, that can be fibrotic in the more chronic stages or non-fibrotic. DAT, remember that can also progress to fibrosis. PPFE is always fibrotic, and LIP is pretty much always non-fibrotic. And then the alveolar filling disorders, besides organizing pneumonia, RB-ILD, DIP, which is AMP, alveolar macrophage pneumonia, they've added all of this. Acute eosinophilic pneumonia, chronic eosinophilic pneumonia, pulmonary alveolar prognosis, life pneumonia. Why these are now lumped under interstitial disease, I don't know, but that's what they have decided to do. Notice that they left out sarcoid. It makes no sense to me, but this is what they've decided to do. And they want now some kind of indication of your diagnostic confidence. If your diagnostic confidence is greater than 90%, it's a confident diagnosis. 70 to 89% provisional with high confidence. Further evaluation may be informative. And then here, low confidence, and if your confidence is less than 50%, consider it unclassifiable ILD, just give her differential diagnosis. Okay, so that is now the new proposed classification scheme for interstitial lung